Good morning. Today we're going to discuss the third line of defense, which is the adaptive immune system. Adaptive or a specific or acquire immunity, which is not present at birth. It is learned, and a person's immune system encounters foreign substances which are antigens. We discussed in the prior PowerPoint the definition of antigens, which are the components of the acquired immune system learn the best way to attack each antigen and begin to develop a memory for that antigen. So it's a foreign body that our immune system tends to recognize, present to the immune system, and attack. Acquired immunity is also called specific immunity because it tailors and attacks a specific antigen previously encountered. So you would see in this presentation that there is a primary response and a secondary response, already recognized antigen, and the immune system creates memory and attacks it. It is the hallmark and it has the ability to learn, adapt, and remember. The acquired immunity takes time to develop after first exposure. We discussed innate and inflammation, which is fast. Acquired immunity is more delayed. It takes time, but it creates memory. So it is more effective. So after the first exposure to a new antigen, we develop antibodies. However, afterwards, the antigen is remembered, and subsequent responses to that antigen are quicker and more effective than those that occur after the first exposure. So we have the first encounter, antibodies are released, the immune system creates memory, and after subsequent responses or encounters, this immune system will detect, will remember the antigen, and will attack quicker. We discussed the granulocytes in the innate immunity and inflammation. Today we're going to talk as well about the white blood cells responsible for acquired immunity, which are lymphocytes T, B cells, as well as other cells that participate in presentation of the antigen to the immune system, which are macrophages, dendritic cells, and the histocompatibility complex. In addition, we're going to talk about cytokines. Remember that we discussed these cytokines in the innate and inflammation, and I said that many of the cells in the innate immunity and the inflammatory process help to create a cascade of events and attract other cells to be activated. So in other words, many components of the innate response facilitate the development of the adaptive immune response. As I previously said, inflammation is relatively rapid, is short-lived, but the adaptive immune system, even though it's lower, it is more specific, it is long-lived, and it has memory. So again, what is an antigen? An antigen is a foreign body or a non-self that creates an immunological response. Then the immune system has specificity, and that specificity is created by the antigen-presenting cells and the capacity of the immune system to have memory. Memory is created by B lymphocytes or plasma cells. So there's B memory cells that are formed and remain in plasma for future exposures. So we have the primary and the secondary response, and we will discuss today as well active and passive immunity. So if you remember in prior PowerPoint, we talked about macrophages and monocytes, which monocytes, if you recall, are the precursors for the macrophages. And the monocytes migrate into the tissue to first influence the colony stimulation factor, in addition to stimulate fibroblasts, in addition to trigger the secretion of cytokines and mastocyte degranulation, and more important, for phagocytosis. Macrophages as well stimulate the granulocyte colony stimulation factor. Macrophages kill intracellular organisms and activate and secrete cytokines, which are interleukins and tumor necrosis factor, and potentiate the secretion of these factors and increase the expression of adhesion molecules of endothelial cells, providing destruction of the pathogen as well as phagocytosis. So the antibodies, we have T cells and we have B cells. The B cells or plasma cells are the one in charge of production of antibodies. And those are the one who combat antigens, whether are chemicals or biological. So as well, there is the antibodies are called immunoglobulins, which they're products of the adaptive immune system, and they have specificity and they have memory, which are the main primary characteristics of antibody and the adaptive immune system: specificity and memory. You would see that there is primary and secondary lymphoid organs. When the baby is inside uterus and before birth, the production of antibodies is mediated by the thymus, as well as bone marrow, but the bone marrow is completely immature. So the baby has to use its primary organ, which is the thymus, which this thymus will atrophy through the years and even before 5 years of age, and the bone marrow takes over for the production of antibody. There are other organs which are called secondary lymphoid organs that also participate in the adaptive immune system. You would see that in addition to those thymus and bone marrow, there is liver, the spleen, the Waldeyer patches of the throat or pharynx. And if you carefully pay attention, there are many disease processes, autoimmune diseases, that the patients would have hepatomegaly, splenomegaly, and also lymphadenopathy, cervical, and even inflammation of the tonsils, because this is no more a response or an active response of the adaptive immune system by secondary lymphoid organs, trying to replace the primary lymphoid organs when they're damaged. This also occurs in leukemias and lymphomas. So an immune response can be divided in two phases. Before birth, the production, there's a large production of T lymphocytes as well as B lymphocytes. But again, the capacity of that is mandated by the thymus. Then there's a population of lymphocytes that will present the foreign antigen. And this group is called generation of clonal diversity. So it is native cells of the lymphoid system that migrate to the thymus and bone marrow and are in charge of recognition of the antigen and presentation as well. In addition to the clonal diversity, there's clonal selection. And in the clonal selection, the lymphocytes will remain dormant until the antigen initiates the second phase of the immune response. Basically, the antigen-presenting cells are in charge with the clonal diversity, along with macrophages and dendritic cells, for recognition, binding, and also presentation of this antigen to the immune system. So, as previously stated, remember that the leukocytes cannot act from the lymphoid tissue directly. They have to migrate from the capillaries to the area of infection or inflammation. And if you remember, this is done by margination, pavimentation, and diapedesis. The same way, the antigen cannot act directly. They must be presented, and this is mandated by the antigen presenting cell, by the clonal diversity cells, as well as for the dendritic and the macrophages. So in this group of cells, you would have the T cells that facilitate immune response, which are the helper T cells, the B cells that are in charge of the antibody producing cells from the plasma cells, as well as dendritic and the macrophages. The adaptive immunity is divided into humoral and cellular. Humoral immunity is mediated by antibodies. So if we said that the plasma cells or lymphocytes type B are in charge of production of antibodies, then it is common sense that humoral immunity is mediated by lymphocytes type B or plasma cells. Same way as cellular immunity, if it involves the activation of macrophages, natural killer cells or cytotoxic T cells, it is common sense that cellular immunity is mediated by lymphocytes type B. Now, there's another way to explain active and passive immunity. Active immunity is no more than that adaptive immunity that is created by a natural exposure to an antigen or an after immunization. When you are exposed to a particular disease process, that is an active natural exposure. If you have hepatitis, antibodies created against hepatitis B is an active immunity. Any disease process that you were exposed to, you create antibodies, and that is active immunity. Or any type of immunization, influenza vaccination, hepatitis B vaccination, MMR, any type of vaccination, including toxoids. Passive immunity is either created by preformed antibodies or T lymphocytes that are transferred from a donor to a recipient. So, in other words, passive immunity does not involve the host immune response at all. It occurs when preformed antibodies are given to the patient in a form of immunoglobulins. So if a patient has myasthenia gravis or Guillain-Barré and you give an infusion of immunoglobulins, this is passive immunity. And passive immunity is temporary, whereas active immunity is long-lived. So again, as I told you, the antigens cannot attack on its own. They must be presented to the immune system before they develop an immune response. And this is done by, again, the antigen-presenting cells. If we come back here, the clonal diversity, the antigen-presenting cells, the dendritic cells, and the macrophages. In addition to that, it is done by other molecules that are called cluster of differentiation. And those are proteins found on the surface of lymphocytes and other cells in the body, but most abundant in lymphocytes. It could be present in erythrocytes as well, in the intestine, but most commonly in the lymphocytes, in the surface of the lymphocytes. They basically identify the antigen and present the antigen as well. Now, not all the antigens are immunogens. For an antigen to be an immunogen, they must induce an immune response. So basically, again, what is an antigen? It's a molecule recognized by the immune system. It's a foreign molecule. It's a non-self that has to be presented to the immune system by either the antigen-presenting cells, the clonal diversity, the cluster of differentiation, dendritic cells, or macrophages. And what is an immunogen? Is that antigen that is able to create an immune response. And in order for an antigen to be an immunogen, they must meet a criteria. And that criteria is foreignness, the size, the complexity, and the quantity. So to explain a little bit more about that, remember that we have self-antigens. So the body tries to allow self-antigens, try to allow the immune system to prevent recognition of the self-antigen by lymphocytes and antibodies. So we do have in our body self-antigens that our immune system has the capacity to allow those self-antigens to persist. And that is called central tolerance or tolerance. And to prevent the recognition of that self-antigens by lymphocytes and antibody. When that criteria does not take place, then we develop an autoimmune disease. It could be lupus, scleroderma, rheumatoid arthritis, any other immunocompromised disorder. Now, when the body does not recognize the antigen as self, is a non-self, and therefore has the criteria of foreignness. And every antigen that is foreign will be an immunogen because it would develop, it will create an immune response. Size, the larger the molecule, the larger the antigen, the more immunogenic. For example, if the antigen is too small, it does not create an immunogenic response, and those are called haptens. Antigen as well could be or could create an allergic reaction, and those antigens are called allergens. And the quantity is the more or the larger the population, the more an immunogenic reaction. Now, what is an epitope? An epitope is no more than an antigen binding site. So that portion of the antigen that is created for recognition is called epitope. And the binding site of the antigen with the antibody is paratope. We talked about the self-antigen, that we do have self-antigen. Again, the body has to recognize the self from the non-self, and that self is called self-antigen that we normally have naturally in our body, and we have the ability, or the immune system has the ability, to recognize as self and prevent the immune system to attack it, and that is tolerance. So we need to develop central and peripheral tolerance with the self-antigen or for the self-antigens in order to avoid autoimmune diseases. We discussed already the hapten and the allergen. Now, for antigen presentation, as I said, there is a complex of group of antigen that can stimulate the immune response directly. These are T cells depending acquired immune system response that typically require an antigen presenting cells to present that antigen peptide within a major histocompatibility complex. So what is the histocompatibility complex? It's a group of glycoproteins that are present in the surface of the human cell except the RBC. We talked about that the most common area of presentation is the lymphocytes, okay? And the antigen presenting cells could be located in the RBC, but the major histocompatibility complex is not present in the RBC. Those are referred as HLA as well, or human leukocyte antigen. I don't know if you remember that when a patient has to go through transplant, the matching is based on the human leukocyte antigen, or HLA. And many other autoimmune diseases, remember that they have a genetic alteration of the HLA. If you remember the pathophysiology of diabetes, it's HLA related because it's an autoimmune disorder, the same as hypothyroidism. So HLA is a major contributor for tissue rejection. We have intracellular antigens and extracellular antigens. Intracellular antigens, for example, could be viruses that can be processed and presented to the T cells, CD8 in this case cytotoxic, by any nucleated cell, because all these nucleated cells express to the major histocompatibility complex. For example, cytomegalovirus will be an intracellular antigen. An extracellular antigen must be processed and complexed with surface class of major histocompatibility complex and be recognized by the CD4 helper cell. So you have the CD8, which is the cytotoxic T cell, and the CD4, which are the helper T cell, which are the major two types of cells, T cells, that are present in the pathophysiology of HIV. So the major histocompatibility complex that participate in antigen-presenting cell, in this case will be the B cells, the monocytes, the macrophages, and the dendritic cells. You have several types of major histocompatibility complex, which is class 1 through 3. And you have pictures of it. See how they are expressed in different chromosomes. And this is again very important for the pathophysiology of transplantation. Okay. Now for recognition, remember that the antigen cannot attack directly. They have to be presented. They has to be recognized by the immune system first in order to develop an immune response. So B cells have receptors as well as T cells have their own receptors, and they will create an immunological response and the production of antibodies, which again, antibodies are called immunoglobulins. There are many types of or classes of antibodies, and these are IgG, IgA, IgM, IgE, and IgD. These are the antibodies. Another picture of the antibodies. Now you must memorize this slide for your exam. So what is IgG? IgG is the most prevalent class of antibody. It's produced when a particular antigen is encountered again. So remember, primary and secondary response. More antibodies is produced in this response, and it's called the secondary immune response. That is in the primary immune response. The secondary immune response is also faster, and the antibody produced mainly IgG. And again, it's more effective. So IgG is the most abundant class. It is more protective. It is released in the secondary immune response. It's not inactive. It would be in passive immunity. Give me 1 second. So IgG protects against bacteria, viruses, fungi, and toxic substances. IgG is presented in the bloodstream and tissues, and is the only class of antibody that crosses the placenta from mother to fetus. The mother's IgG protects the fetus and infant until the infant's immune system can produce its own antibody. So again, IgG is the most common class of antibody for prior exposure as well as for chronic diseases. Then we have IgA, which IgA help defense against the invasion of microorganisms through body surfaces lined with the mucous membrane. So your key word there will be secretions. So the secretory component that protects this type of immunoglobulins. So again, it is present in the surface of mucous membranes. For example, the nose, the eyes, the lungs, the digestive tract. IgA is present in the bloodstream in secretions produced by mucous membrane and in colostrum as well. So the fluid produced by breast during the first few days after delivery and before breast milk is produced is mandated by IgA. You have two classes of IgA, which is 1 and 2. You don't need to know that part. So basically, IgG is the most abundant, is the most protective, is present in secondary response of the adaptive immune system. It represents prior exposure or chronic diseases. IgA is present in mucous membranes that produce or have a secretory capacity. Then we have IgM, which this class of antibody is produced when a particular antigen, such as an antigen of an infectious microorganism, is encountered for the first time. So it determines active disease. Whenever you have a disease process, the antibody that is released in a primary response or for the first time is the IgM and signifies acute disease. I apologize, it's the phone ringing constantly. So the response triggered by the first encounter with an antigen is the primary immune response. IgM attaches to the antigen, activating the complement system and thus make the microorganism easier to ingest. Normally, IgM is present in the bloodstream but not in the tissue. So when IgM is present in the tissue, it signifies an active disease. It does provoke, of course, the activation of other immunoglobulins. IgD will be mainly in B lymphocytes. It helps these cells to mature, and small amount of these antibodies are present in the bloodstream. Their function in the bloodstream, if any, is not well understood. And IgE signifies an allergic reaction. And that allergic reaction could signifies anaphylaxis, could signifies also parasitic infection. So these antibodies trigger immediate allergic, that's your keyword, allergic reaction, as well as parasitic infections will activate the production of IgE. So it does bind to basophils in the bloodstream and in the mast cells. If you remember, mast cells, when they degranulate, the first cytokine that is released, or the first pro-inflammatory mediator, is histamine. And histamine, if you remember, H1 is present in the bronchioles and epithelium as well, and is activated during an allergic reaction. So when basophils or mast cells are activated, IgE bound to these allergens and they release histamine that creates an activation of the inflammatory cascade So IgE is the only class of antibody that often seems to do more harm than good because it could create an anaphylactic reaction. However, IgE again helps defend against certain parasitic infections. So a small amount of IgE are also present in the bloodstream, the mucus of the digestive system. Remember, you have an H2, which is present in the digestive system to enhance the production or, hydrogen chloride or acid in the gastric environment or decreasing the pH of the stomach. Now, let's talk about antigen binding. No, actually, I went, yeah, well, yes, it's more or less the same. It's no more than, it's an amino acid sequence that every single antigen must fit into this binding site. It has to create a specificity like a key into a lock. This is the most important part here. So that the antigen and the antibody must create a chemical reaction, must be so specific that it must fit like a key in a lock. Now, we talked about clonal diversity, and remember that clonal diversity is part of the immune system that participates in antigen presentation. Remember that this immune system has a primary central lymphoid organ or a secondary lymphoid organ. Remember that primary lymphoid organs are the thymus, and it occurs primarily in the fetus. So all the lymphocytes B and T are created in the neonates and the fetus in the thymus, that this thymus atrophies and then takes over the bone marrow, which is another primary lymphoid organ. Then we have the secondary lymphoid organs that are also present as an adjuvant for the immune system. And this could be the spleen, the liver, the Waldeyer patches of the pharynx and intestine as well. The intestine could be inflamed or develop an autoimmune response when patients would have an autoimmune disorder as well. For example, Crohn's disease and ulcerative colitis, this activation of the Waldeyer patches of the intestine, because this is an autoimmune response and the body is trying to help the bone marrow to function, to have a proper function of the adaptive immune system, which is the third line of defense. Then again, we talked about the antigen processing and presentation cells that besides the prior group of cells that we discussed, I explained that dendritic cells, macrophages, and B lymphocytes also participate. Now, let's talk about T lymphocytes, which are the helper T cells. So T cells are no more than cells that develop from the bone marrow stem cell that travel to the thymus, where they go through a rigorous selection. And there are three main types of T cells. There's the helper, regulatory, and cytotoxic T cells. In this selection, T cells react to a self-antigen presented by the major histocompatibility complex and are eliminated by apoptosis. Only T cells that can recognize the non-self antigen complex between the non-self and the self will survive the major histocompatibility complex. So they leave the thymus from the peripheral blood and lymphoid tissue. Most mature T cells are expressed either as CD4 or CD8 and have an antigen binding, like a T-like surface receptor or B-type surface receptor. So the T lymphocytes are the helpers. They facilitate and magnify the interaction of this antigen-presenting cell or histocompatibility complex when the patient, of course, is immunocompetent. And there are many steps that you don't have to memorize. Basically, it's the interaction between the antigen and the antibody that, after undergoing differentiation, matures into the plasma cell that creates antibody. So this is the antigen presentation cell. So this is the antigen, and it has to be presented to the immune system. So there are phases of antigen capture by dendritic cells. Inflammatory response, cytokines are released. So there is adhesiveness and migration. Remember that the leukocyte has to migrate in order to create an immune response, in order to be immunogenic. Now, for the antigen presentation cell, in addition, there is release of many interleukins. And the interleukins stimulate T cells for proliferation and differentiation. In addition, they induce B cell proliferation as well as chemotaxis. There is a humoral and cellular immune response, as I discussed prior. Remember that the production of B lymphocytes, the activation of B lymphocytes with the production of antibody is a humoral activation, it's a humoral response by the plasma cells. Okay, we have again primary and secondary lymphoid organs that are activated during this process. So there is a primary and a secondary response that I already explained prior. So basically, there is initial exposure of the antigen. The antigen is presented into the immune system. Then there is a lag phase or latent period that at that time B cell is getting differentiated. IgM is produced at the primary response. Remember that IgM is present during an active disease process, an active immunity, whereas IgG is released in a secondary response and is longer lived and is signified prior exposure or chronic conditions. Then again, secondary response, yes, it is more rapid because the immune system has created memory. There is a larger amount of antibodies that are released, and even though IgM is produced, it's produced in a very small quantity. Here is where IgG is produced in high amounts and signifies, again, prior exposure or chronic condition. Here you have the picture of the antigen presenting cell to the immune system and how that signals the activation of the complement cascade as well as release of interleukins and, of course, activation of the plasma cell and production of antibodies. Now, in addition, there is activation of the T cells that, again, the T cells are the killers. So they regulate the immune response to avoid attacking the self, but recognizing the non-self and killing it. Both antigen processing and presentations are necessary for the adaptive immune response to occur. This is an activation again. Now, we also have in our immune system what's called super antigens. And super antigens are those antigens that are able to produce an exaggerated response in the immune system. And it has to be an excessive response, such as, for example, in toxic shock syndrome. So patients will be basically in shock, or severe sepsis, causing fever, hypotension, and this again is created by super antigens. Now, the function of the antibody, it could be direct or indirect. And this could happen directly, um, mediated by neutralization, which is inactivating or blocking the bindings of an antigen to a receptor, agglutination, which is clumping insoluble particles that are in suspension, precipitation, which is making a soluble antigen into an insoluble precipitate. This is not important. And also indirect effects that are basically by opsonization. Remember that opsonization is tagging of the microorganism to be attacked by or presented by the immune system. Now, there are other mechanisms of killing mediated by the T lymphocytes. Okay, and these are um, basically destroying cancer cells, producing apoptosis, activating the complement system by the natural killer cells, and as well as try to always create tolerance to the self. These are the cell killing mechanisms. Remember that we talked about apoptosis prior. That is what? Um, Programmed cell death. Okay, so finally, um, the fetal and neonatal, we discussed prior that the immune system will produce primary and secondary lymphoid organs. The primary lymphoid organs in the fetal and the neonatal will be the thymus. They have the capacity of creating a primary immune response and releasing IgM, but they're unable to create a secondary immune response and produce IgG. So they're challenged on that. They do have the capacity to produce IgA, but it's underdeveloped, so it's low. In addition, they received immunity by maternal antibodies through the placenta. So these are the majority of the babies. How do they obtain immunity mainly? So at birth, total IgG levels in the umbilical cord are near adult level. But by itself, fetal, they do not produce IgG or secondary response. Okay, so it's basically by placental circulation. And in the elderly, um, because of old age and they don't have thymic or thymus, it's already atrophy. They rely mainly on the bone marrow, but the bone marrow has decreased capacity already, so they're also at expense of the secondary lymphoid organs. So spleen, liver, while there are patches of intestine, they rely on those secondary lymphoid organs as well. They do have an increase in circulating antigen antibody complexes. They're more exposed to non-recognition of the self, so they have higher increase of autoimmune disorders, and they do have decreased circulating memory B cells. So this is the end of this PowerPoint in adaptive immunity. So what you have to recall in this PowerPoint is basically you need to know antigen presenting cells. You need to know the difference between immunoglobulins